Welcome, fellow detectives of medicine. Today, we're on the trail of a silent, dangerous culprit that lurks in our wards: increased intracranial pressure. So, grab your magnifying glass because our investigation starts right now.
You know, this isn't just some clever riddle. It's the central problem we face every single day when that locked room is the human skull. How do we get a look inside, figure out what's going on, without causing a bunch of collateral damage? That's the name of the game.
And here's our number one suspect: increased intracranial pressure, or ICP. This thing often shows up after non-traumatic injuries like strokes, brain bleeds, or infections. And let me tell you, catching it early is absolutely critical. It's a really stealthy adversary. Its first signs can be super subtle. But if you miss them, well, it can lead to some truly devastating outcomes. So, how do we traditionally measure this pressure? Well, the methods we have are definitely effective. But they come with a pretty significant catch. They require let's say, a rather forceful approach to get the answers we need. And this right here is the trade-off we're always facing. We can get a direct confession from the brain using these invasive monitors. They're basically our battering rams. They give us that gold standard accuracy we want. But the interrogation itself, it's risky. We're talking infection, bleeding. It's an effective move for sure, but it is a very high-stakes one. But what if there were a better clue? A non-invasive way to just peer inside that locked room. You know, a clever detective is always looking for a smarter way in. And this is our new magnifying glass ONS sonography. It's a simple ultrasound probe that takes advantage of a brilliant little piece of human anatomy. I mean, just think about it. A tool you can carry right in your pocket, ready to use at the bedside for a super quick assessment. No waiting for a special team. No breaking a sterile field. It's a game changer. So you might be asking, how does this even work? Well, it's pretty elementary, my dear doctor. The eye is a direct extension of the brain, connected by the optic nerve. So when that pressure inside the skull rises, it literally pushes cerebrospinal fluid down into the optic nerve sheath, making it swell up like a little balloon. It's a direct, measurable sign of what's happening inside the head, our perfect telltale clue. Now, a good detective needs cold, hard evidence, not just a hunch. So let's open up the case files and look at a huge 2025 meta-analysis to see just how reliable this clue really is. We are about to see how it performs out in the field. And this investigation was extensive. We're talking nearly 1,500 neurocritical patients from all over the world. So this isn't some small-time operation. This is a major inquiry into the facts. Okay, get this, a sensitivity of 92%. In detective terms, that means if the culprit, IICP, is in the room, this tool is going to spot him 92% of the time. Clinically, that means it is exceptionally good at correctly finding the patients who do have increased intracranial pressure. You can be really confident you're not missing the diagnosis. And just as important, a specificity of 90%. This is all about clearing the innocent. It means the test is also excellent at correctly ruling out the condition in patients who don't have it. And here's the crucial point. We get fewer false alarms. We're not off chasing ghosts, we're focusing our attention right where it needs to be. I mean, when you see the numbers laid out like this, visually, you can just feel how powerful they are. We're looking at a tool that performs incredibly well on both fronts. This isn't a coin toss, not even close. It's a highly reliable diagnostic clue that can absolutely change how you manage your patient at the bedside. So this number, 0.925, is the area under the curve, or AUC. The easiest way to think about it is as the overall performance score of our detective tool. Any score above 0.9 is considered excellent. So at 0.925, ONSD sonography isn't just a good clue. It's a top-tier grade A diagnostic instrument. The evidence is just overwhelming. Okay, the evidence is compelling, it's rock solid. But any master detective knows the strengths and, just as importantly, the weaknesses of every tool in their kit. So how do we actually use this magnifying glass effectively in our day-to-day practice? All right, think of this as your field guide. Use ONSD sonography to quickly screen and assess any patient you're worried about. It's fantastic for that first look. But, and this is important, remember, it's a snapshot, not a continuous movie like an invasive monitor. Also, you have to be aware that the exact cutoff number for high pressure might vary a bit, and certain conditions like a subarachnoid hemorrhage might play by their own rules. One size does not fit all. So here are the key takeaways, the things you really need to remember. ONSD sonography is a strong, evidence-backed ally in our investigations. But please remember, it's a powerful clue, but it's not the final verdict. Always, always integrate it into your full clinical investigation. The more you practice, the better you'll get, and this skill is going to make you a more confident, more capable clinician at the bedside, ready to solve the case and protect your patients. You know, the optic nerve sheath was always there, a clue hiding in plain sight. And with this simple, elegant tool of ultrasound, we finally learned how to observe it and to understand the critical story that it's telling us. And this leaves us with a really provocative thought about the future of neurocritical care. As our non-invasive tools get better and better, more and more reliable, are we going to need to break down the door quite as often? The game, my dear doctor, is afoot.